Tai sveiki visi, labai diena. Ir Vilniaus Universiteto suicidologijos tyrimų centro vardu sveikinu visus čia šiandien susirinkusius. Labai džiugu matyti tokį gausų būrį žmonių ir turbūt, ne veltui, nes turim tikrai vieną iš suicidologijos mokslo žvaigždžių pas mus šiandien svečiuose. Ir jeigu jūs nieko prieš, kad pristatyčiau profesorių Mishara persijungusi į anglų kalbą, kad visi galėtumėm suprasti. So, it's a huge pleasure for me to introduce Professor Mishara today, who's today in here with us. And why it's so great to have, it's an honor actually to have one of the top researchers in the world in the suicidology field in here and have to hear a lecture from him. Professor Mishara is the founder and director of the Center for Research and Intervention on Suicide, Ethical Issues and End-of-Life Practices in Canada, in Montréal, and he is a professor at the Quebeko University. He is also the past president of the International Association for Suicide Research. So you can imagine this is a person who has spent his whole life doing research on suicide and best suicide prevention practices. And it's a great honor to hear him speaking today about understanding suicide and suicidal behaviors and what can we do best to prevent them. So please give a warm welcome to Professor Mishara.
Thank you very much for the kind introduction. What I'd like to do today is almost an impossible task, to summarize what we know about why people are suicidal and how to prevent suicide in less than an hour. So my goal is not to completely inform, but rather to at least get you interested so that if there are topics you want to explore, you might go ahead and do it. So what I'm going to do is I'm going to talk very briefly about suicide in the world. I'm going to give my simple explanation of why people commit suicide. I'm going to talk about best practices in suicide prevention from a research perspective. I'm going to talk about some challenges or difficulties in research on suicide prevention. And then, just to tantalize you a little bit, I'm going to talk about some strategies for increasing hope, based on some work I've been doing in Africa. And I'm going to talk about a success story where I come from, how suicide in Quebec has dramatically increased and what's been going on. And I'll have some conclusions. So that's a lot for an hour. We'll start. So suicide has always existed. Now, I can't read this, but this is tablet number 256 of what is known as the man who was tired of life. And this man wrote over 1,000 years ago in Egypt a series of tablets. I guess he chiseled them away. And it's basically an inner debate. Should I kill myself or should I not kill myself? And when you listen to this debate that he's having, if you eliminate the parts that were specific to ancient Egypt, about this voyage in the afterlife and so forth, that person could be you or your neighbor. He had classic symptoms of clinical depression. He would wake up early in the morning, unable to get back to sleep. And he had many of the characteristics of the sort of ambivalence and what's going on and feeling the weight of the problems that we see now. So suicide has always existed. Suicide exists in every country in the world. There's no place, city, village where there are no suicides or never been any suicides. This is the latest World Health Organization map, and the redder it gets, the higher the rates, and you will see that Lithuania is in the highest rate area, having not the highest rate in the world, but one of the higher rates in the world, even though suicides have been going down. So there's about 800,000 suicides a year in the world. What is interesting to me is that we pay so much attention every time there's a terrorist attack, or there's a few hundred people or thousands of people who are killed in a war. But there are more than double the deaths by suicide each year than in all wars and terrorist activities combined. There are more suicides than there are homicides in wars. So more humans each year kill themselves than kill other people. Yet we pay much less attention to this. And so for every suicide, there are a number of people bereaved. It's hard, depends on how you calculate it, but there are many more attempts than there are completed suicides. I'm going to talk about that. Globally, the highest risk rate is people 70 and older, or 85 and older, and there are exceptions. For example, where I come from in Quebec, Canada, the elderly have the lowest suicide rate of all age groups until recently, where the youth rate has gone down so low that they have a lower rate now. And most suicides occur in low and middle income countries and in high income countries. And you may not believe it, but Lithuania is probably in that category. Men die by suicide about 3 or 4 times more than women. But in poorer countries, particularly in Asia, it's almost equal. And there are some areas of China and India where women die by suicide more than men. Even though the rates are low for young people, because young people don't usually die by other means, they don't get cancers or heart disease, the main causes of death of humans. Suicide is the second most common cause of death in people 15 to 29 years old around the world. And if we look at that chart and we see low rates, some of the countries that have very low rates, it's not because they have low rates. It's because they're countries where suicide is a taboo, as it is in all Muslim countries where killing yourself is one of the worst sins possible. And they don't report, or they just don't have good reporting systems to count suicides. So if you ask the simple question, why does someone kill themselves? I believe that the answer is always the same. There are differences. There are different pressures in different societies. There are some very specific phenomena of suicide, like in India, just when school exam results come out and people find out whether or not they can go to university. There's high rates among those who will never be able to ever go to university in their life because they failed this one exam. But basically, all people who die by suicide kill themselves to stop suffering. They suffering which they think is interminable. It will never end. Unavoidable. There's nothing I can do to stop suffering. And insupportable, I cannot go on suffering like this. And the key word is the word think. So if you have a 16-year-old boy or adolescent and his girlfriend left him, and this is the first girl he ever dated, and he's madly in love with her, and she left him, and he thinks that this is the end. There's nothing I can do about it. It's over. I'm never going to love anyone again for the rest of my life. There's nothing I can do about it, and I'm suffering so much. I'm always going to feel this pain because she was the love of my life. Now, you can look at this young person and you could say, that's ridiculous, you're 16. You'll fall in love again, you'll get over this. But if at that moment, that is what he is feeling, he can go ahead and attempt suicide and even die by suicide from that attempt. So it's from the point of view of the person. Some people experience the most horrendous situations you can imagine, and they never even think of suicide. And other people appear to go through situations where it just seems like there are things they can do to make it better. It's going to end. And yet, they will go ahead and kill themselves. Obviously, some things like being drunk at the moment, being under the influence of alcohol or drugs, can influence what we think. We don't make good decisions when we're very drunk or inebriated. So, but it's based on what the person experiences at the time. Suicide is still a rare event. It is a rare event because most people, even when they intend to go ahead and kill themselves, change their mind. So for every person who seriously, who dies by suicide, there are thousands, probably. So suicide rates are about, average for the world, 12 or 13 per 100,000 people. There'll be 2,000 to 4,000 every year who seriously think of killing themselves. If you take away the word seriously and you ask people in any country or society, have you ever thought of suicide? Most people have. If you have not thought of killing yourself ever, you are in the minority of human beings living on Earth. And for the older people in the room, I say think back on when you were a teenager and adolescent, and maybe you'll remember those moments. Thinking about suicide is normal. I mean, I can think about anything. I can be giving this talk and say, it's a beautiful day. I'm going to just stop, go outside, and take a walk around Vilnius. But it doesn't mean I'm necessarily going to do it. I mean, we can have all sorts of thoughts. Even people who attempt suicide don't usually die. There are hospitalized attempts, at least 20 for every person who dies by suicide. And if you ask people, have you ever attempted suicide, you'll get many more, up to 100 for everyone who dies by suicide. But some of these you wonder and some not. Some people take something to kill themselves and they wake up the next morning and they're okay. But most people who are so serious about suicide that they go ahead and start an attempt, if they can, they will get help. They will call a helpline. They will try to vomit. They will stop cutting themselves. If they went to jump off of a high place, they'll go back. And even people who seem very determined, most will not die by their attempt. when we had a meeting on suicide, International Association for Suicide Prevention meeting in Montreal a few years ago, a man by the name of Kevin Hines talked about his experience. And he's one of the few people who jumped off of the Golden Gate Bridge in San Francisco and survived. And there's over 1,000 people who have jumped and have died. It's a very high bridge and it's very difficult to survive. And he told the story of having suffered from mental health problems, having tried medications and therapies, and it didn't seem to work or help. And he planned his suicide. When he walked on the bridge, he had gotten rid of his apartment, he had mailed letters. It's a few years back. There were things called letters that we put stamps on. We put them in postal boxes. I know some of you don't know about this, but it was in the old days. And he sent letters saying it's not your fault and sent it to his family and friends. And he said all he owned when he walked on the bridge was the clothes he was wearing. And it was a beautiful day, and he was standing on the bridge, and the barriers, there's a little fence about this high, and he was looking down, and he said, such a beautiful day. If someone tries to talk to me, maybe I'll stop and do it tomorrow. And a woman came up and said, he's looking over the bridge, said, sir, sir, sir. And he said, yes. Could you take our photograph? And he took a photograph of a couple and gave them the camera back. And then he jumped off of the bridge. And he said that for months, that's all he thought about was ending his suffering by killing himself. And as he was falling to his death from the bridge, he said to himself, I just made a very big mistake. I want to live. But he was falling to his death. And somehow he managed to turn around. He hit the water and broke his feet, his ribs, and 3 things saved him. The first was sort of unbelievable. A sea lion's like a seal, was swimming there and went under him and brought him up to the surface. The second thing, there was a woman on the bridge whose husband worked for the Coast Guard in the harbor. She saw him jump and she called her husband on the portable phone and said, a man just jumped off the bridge. He turned the boat around and he was there in 3 minutes. And when he came to the surface, the boat was there and they grabbed him. And then they brought him to the emergency room. And they said, well, he may survive, but you're not going to be able to move any part of your body from your neck down because it looks like your spinal cord is broken. But wait a minute, we have someone giving a lecture upstairs. He's a world expert surgeon in spinal cords. Maybe he'll come down. And he came down and he operated and he can walk and he's fine. And he works in suicide prevention now. So it's very tragic when someone dies by suicide because the rule is most people get help. So it's tragic when people don't. So most suicides are prevented, but because it's rare, if you want to prevent suicides, you have 2 options. You have to cast a wide net. So you have to do things which will touch everyone so that you make sure you pick up the suicidal people, or you have to be very good at figuring out who's at risk and target the people who are at risk. We'll come back to some of this. Now, if you pick up the 2014 report of the World Health Organization on suicide in the world, it's available free to download on the WHO website, you'll see something which is always repeated: suicide is multi-determined. And even though most people in Western countries who die by suicide have a diagnosable mental disorder, up to 90%. It's not the case in Asia or in Africa, where it's not even, it's less than 50% usually, using the same methods, very reliable studies. But a small number of people with a mental disorder will still die by suicide. Suicide results from a combination of risk and protective factors. And I'm going to explain how I understand suicide. So suicide begins with an insupportable problem. And I put the word insupportable in quotation marks. Those are French quotation marks. I come from the part of Canada where we speak French. My university is a French-speaking university in a French-speaking province of Canada. And I put it in quotation marks because, as I said earlier, it's from the point of view of the person. The same problem for one person might be the end of the world. I can't tolerate this. And for someone else, so what? So he left me, you know. And so when we have a problem, we look for ways of dealing with it. Sometimes we think about it. How am I going to deal with it? Sometimes it's mechanical. So what do? My girlfriend leaves me. What do? I go and I buy a bottle of vodka and I drink the whole thing. That's a way of dealing with the problem. It may not solve the problem in the long run, but I might feel better, I might feel worse. I could pick up the phone and call a friend. I can call my ex and see if she's still available. I could try to patch things up. I could send her some flowers and say I'm sorry for whatever it is that upset her. You know, I can do whatever things, but if it looks like this is a horrible change in my life, you know, I love her and she left me for my best friend, and what am I going to do? And I can't, I'm suffering and I can't go on like this. It's normal to think if I, you know, you can't really read this, but if I kill myself, my suffering will end. It's normal. As I said, it's just a thought. We can think anything, but it doesn't mean we're actually going to do it. Now, in order to actually go ahead and do it, you have to intend to do it. You have to say, I'm going to go and kill myself. But even intentions are not necessarily sufficient. So, for example, if you visit my office in Montreal, there are piles of papers everywhere. And if you said to me, Brian, when are you going to clean the office? It's a mess. My answer would be, honestly, I'm definitely going to do it this week. But I've been saying that since January. So and I really intend to do it this week. But somehow, I haven't done it. So even someone who intends to kill themselves, it doesn't really mean that they're going to go ahead and do it, but you have to decide that you're going to do it. You need something to motivate you to do it. And in the case of suicide, this is usually what we call a precipitating event. Usually something occurs that day, that week, which is just, you know, if things are bad, I've been thinking about killing myself, but this is it. And very often we are confused. We think that this precipitating event is the cause. So, you know, we're feeling unhappy and depressed, and things are not going well, and I lose my job, or my girlfriend leaves, or a young person has a horrible fight with his parents. And we say, oh, he did it because his girlfriend left, or he had a fight with his parents, or whatever. But this is usually the last straw, the precipitating event for someone who is already vulnerable, which sort of determined that today this is going to happen. In the case of suicide, even if you're determined to go ahead, you need something else. And what you need is access to acceptable means. And if I went around the room, and I don't have a lot of time, so we won't do this, and said, you have to kill yourself, how are you going to do it? You know, some people will choose a gun. Other people would be horrified of choosing a gun. Some people will use medications. Others will say, will not. We all have means we find more or less acceptable. And there are cultural differences. For example, in India, people will buy some gasoline or kerosene and set themselves on fire. And this is a way to kill yourself, and very popular. But in Lithuania, people don't think of doing that. It's just not acceptable. And that is, so if you have the means available, you're more likely to attempt suicide, and a certain number of people who will attempt suicide, I'm going to take out the word completed, it's not acceptable now, will die by suicide. So that's how I understand the process. Now, there are risk factors which are well established, for example, mental disorders, alcohol and drugs, losses. There's a big category of things which we can conceive of as being losses. And those types of things are very often the types of precipitating events or trigger events, another word for precipitating events. Having the means available makes it more likely you're going to use it. So if my means is to shoot myself, and I have a loaded gun sitting there, that day my girlfriend left, it's much more likely that I die by suicide than if that's the way I'm going to do it, and I don't have a gun, I have to get a permit, and maybe I can get one, or maybe I can't, and it's very, very different if the means are available. You know, if I'm living on the 10th story of a building and I have a balcony and I think that jumping would be a good way to kill myself, I'm much more risky than I'm living in a 2-story building on the ground floor. So having the means available. There are also protective factors. No matter how dangerous the situation, if you have sufficient protective factors, they will counterbalance the risk factors. And the strongest protective factor is in the middle of the list there. It's actually social support. So people, for example, who say that they have a confidant, there is at least one person they can talk to and tell any problems they have half the risk of dying by suicide than people who say, I don't have anyone who I could talk to and tell my problems to. Having social support, and that is one of the reasons that in most instances, being married is a protective factor because of the social support it gives. It is not always the case. For example, in elderly people, when the wife dies, the risk of suicide and life expectancy of the husband decreases and the risk of suicide increases. But when it's the husband that dies, the risk of suicide goes down. And you can interpret this as you want. Okay. So there's also treatment of mental health problems, having some form of crisis intervention, a helpline or some service or someone to help you when you're feeling that desperate. And the other thing is having good coping skills, because I started out by saying that basically suicide is a way of coping with a problem in a situation where we don't see other ways of dealing with the issue. And so if we have good coping skills, that helps protect us as well. Control of access to means prevents death by suicide. If people are jumping off of a bridge and you put a barrier up so that people cannot jump off of that bridge, people won't be able to jump off of the bridge, but very few of them will look for another means. They'll go from the bridge and jump in front of a train or do something else. Very few, because we all, for some strange reason, have our preferences for methods. And when we're frustrated, two things happen. We don't necessarily choose another method, but also it buys time. If I go to the bridge and there's a big fence up and I can't jump off, by the time I find another method, chances are the crisis will have diminished. And about 50% of people who die by suicide have been consuming alcohol at the moment of their death. And you know that when you are inebriated, it's not the time to make big, important life decisions, and including the decision, should I live or should I die? And if we're frustrated from killing ourselves then, we might be sober 12 hours later, too. So there are a number of reasons that controlling access. In the United States, we have states there where they made it harder and then easier again to own a gun. And you can see the changes in the suicide rates. When they make it more difficult to own a gun, the suicides go down. When they make it easier to get hold of a gun, the suicides go up. A house in the United States where there's a gun has 6 times more risk that someone will die by suicide in that house. I mentioned the United States because it's the only country in the world where guns is the #1 method of suicide. Nowhere else, but they also a country where everyone can very easily get guns. Treatment and follow-up. People who attempt suicide have a high risk of attempting again in the following year. Between 10 and 15% will attempt again. If you are an optimist, you will say between 85 and 90% will not attempt again, which is a good thing. But still, 10-15% is a high risk. And what will determine whether or not someone will attempt again is not what happens to them when they're in the hospital, but it's the follow-up that they have after they leave the hospital, and that involves some proactive follow-up. That is, actually going after the person and following up with them, not just giving them an appointment to come in to see someone a week or 2 weeks later, because most people will not come to the first appointment, and even those who come will not continue. So now, in the old days, there was another thing we called postcards that used to exist. They were pieces of paper with pictures on one side, and we would put an address and a stamp on the other side, and you could write a little note to the person, and put it in the mailbox and get delivered to the house. And the first research was in the 1970s, Jerome Motto in California, where he just simply sent postcards every week after someone left the hospital after a suicide attempt. And the postcard said, "I hope you're doing well. Feel free to call us if you need to." No one called, almost no one called. But the people who were randomly picked to get a postcard every week attempted suicide less frequently than the people who didn't get a postcard. Now, we don't do postcards. We send SMS text messages to people every week, checking in on them. Or I have colleagues who are experimenting with a program where your iPhone will check in on you every day and say, "How you doing?" and answer a few questions. And if you're not doing well, suggest some ways to cope with it that you've established with your therapist before. And if you're really not doing well, without even telling you, your telephone will send a message to your friends and family members who said they'd be there to help you, saying, "Brian's not doing well today. You might want to check up on him." And this is all done by your telephone, without any humans involved at that point. But so it's the follow-up that counts. Now, there's a lot of research on suicide prevention. I've counted 7,242 published scientific articles since the year 2000. I have not read all of them, or even a large proportion of them, but there's a lot of publications on suicide prevention. One of the problems with suicide research is that we only include in our scientific studies research on people who accept what we propose. So if I'm testing cognitive behavioral therapy, I want to see if that's effective. I can't force you to do it. So I have to recruit people who accept to have cognitive behavioral therapy. But that's not going to tell me anything about people who say, "No, I don't want that." So it's only people, or try this new medication. Well, I don't want to try any medication. So it's only people who accept the interventions and adhere strictly to the protocol. So if I do a study of CBT therapy, and I'm going to compare people who've had, 3 months of therapy with people who've had no therapy or a placebo or another therapy, but I'm not going to include the people who after 2 weeks say, "This isn't for me," and they leave. So none of that is, most people don't complete their therapy or take the medications completely as they're supposed to, or keep taking their medications. So whenever we say something works, what we know is it works for the people who are already accepting to do it. And this creates a big bias in much of the published research. Because in real life, people refuse treatments we offer, they stop treatment, they don't follow prescribed protocols, and this is very different from the ideal patient for which we have published some data. There's another problem. All the drugs, pretty much all the drugs that are used to treat people who are suicidal have never been tested in a scientific study on people who are suicidal, because if you're suicidal, you're not allowed to participate in the study of the effectiveness of the drug, because the drug company doesn't want people killing themselves while they're doing the research. So they exclude everyone who's suicidal. So the drug might be good at treating depression, but everyone who's suicidal is not allowed to participate in the study. So we have a bit of a paradox here. And so the other issue is that most of the research is done in a few countries, and most of the research focuses on medications, drugs. Why? Because drug companies have lots of money and they give lots of money to do research, professional psychotherapy, and treatment in specialized psychiatric hospital units. We can't control what people are going to study. But for example, 98% of all psychological autopsy studies, a method used for studying suicide cases, come from 10 countries, and those are the countries. I don't see Lithuania there. Most of the published articles are published from the US, the UK, Australia, and so forth. And 88% of publications are on professional psychiatric or medical interventions, because they're the people who have to publish to get their careers advanced, and they're the people who are getting funded, and so forth. But 46% of the countries in the world have fewer than one psychiatrist per 100,000 inhabitants. And 22%, almost, it's 1 out of 5, a little more than one out of 5, have fewer than one psychiatrist for every million people. And so most mental health care is not provided by mental health professionals. Family and community play a major role. I've done some training in Uganda, in Africa, and there are 30 million people in Uganda and 18 psychiatrists. So your chance, and most of them are like hospital directors and professors, so your chances of seeing a psychiatrist, you say 1 in a million, is probably 1 in 10 million or something. So that's the reality of mental health in the world. For the fun of it, now, correlation does not mean causality. So you can't overinterpret this, but there's a positive correlation between the number of psychiatrists per capita and the suicide rates. Basically, worldwide, the more psychiatrists there are, the more people kill themselves. So, I don't know, you can interpret it as you want. Okay. So, when you look at World Health Organization report and you review the literature, and I really don't have time, I want to touch on too many different things to get into it. The sorts of things for which we have scientific evidence that it works is reducing access to means, no matter what you do, whether you put pesticides in boxes, little controversy over how to control pesticide suicides, firearm control, certain medications, bridge barriers on bridges, gates in subways and things like that. That's effective. Reporting by media in a responsible way. If you change how your newspapers, television, internet are talking about suicide, you're going to have fewer suicides. Introducing policies to reduce the harmful use of alcohol. We had a wonderful example of this, because when Gorbachev decided that he wanted to cut down on alcohol problems in the Soviet Union, and he limited how the hours stores were available, and he increased the price of vodka, and he had the police arrest more people from being drunk in public and so forth. Alcohol consumption decreased, suicide rates went way down, domestic violence rates went down, but you know what happened? No one could tolerate that. There were demonstrations in the streets and protests, and finally he gave up and he lowered the price of vodka and let the stores stay open, and whoop, suicide rates went right back up to where they were. Domestic violence and homicide rates went up and so forth. So we know that if you can do it, controlling access to alcohol helps. early identification, treatment, care of people with mental and substance use disorders, chronic pain, and acute emotional distress. Training of non-specialized health workers in assessment and management of suicidal behavior. So just general practitioners, for example, part of the European Alliance on Depression that's a key part of that. And I mentioned this follow-up care for people who attempted suicide and provisions of community support and help in crisis situations. Used to be over the telephone, now more and more it's by text messages and the internet chats and so forth. And the WHO recommends that all countries develop a national strategy for suicide prevention, having all these components, and for time you can just get the document if you're interested. Well, there are a number of challenges. One is stigma surrounding talking about dealing with suicide and mental health and help-seeking behavior, and the need to raise awareness, breaking taboos. As I mentioned, most research money goes to medical research, so we know a lot about what drugs are more or less effective, but we don't know as much about community programs because no one's getting more or less money when we evaluate a community program, whereas a drug company might make a lot of money if their drug proves to be effective and useful. So just some examples: responsible media reporting. I don't think Lithuania is a model of media reporting on suicide. If you look at the latest WHO guidelines, they've just been revised to include new media, internet, and so forth. The more you sensationalize a suicide and publicize about methods and so forth, the more likely that other people will attempt suicide using those methods. Helplines. I've been involved in studying the effectiveness of telephone helplines. Now all our research is concentrating on chat and text message help, trying to determine how to best help someone using those media. We have good ideas and good hard data about how to best help someone over the telephone, and it involves more than just listening, and these are all published things. Very little research on gatekeepers. Gatekeepers are people like first responders, police, firefighters, ambulance workers who arrive on the scene when people are in crisis, informed citizens like teachers or clergy, or professionals who are not mental health professionals. And there are data that some local programs can have very direct impact on suicide rates. So I'm going to start with some conclusions. I'm going to give you some examples. I'm looking at the time because I want to make sure there's some time for some discussion, questions. We need to develop models that fit better, really, in countries where professional mental health workers are not available or usually consulted. In some countries, we have plenty of psychiatrists. It's just that people who are suicidal don't talk to them. Plenty of psychologists, counselors, and helplines. And one of the explanations for the difference in the suicide rates of men and women in Western countries is the fact that women are more likely to talk about their problems than men. And women are more likely to call a helpline. They're more likely to tell their doctor that they're feeling unhappy or depressed. And, this is part of this traditional macho image of men, and we all know it. It's at the end of the Hollywood movie. We've seen these movies. They're the action movie where the bad guy is up in a fortress with 1,000 other bad guys, and he's got machine guns and lasers and all sorts of horrible weapons, and he has the girl who the hero is in love with in the tower, and our hero is down below, and his friend said to him, "You can't go in there. You're not even armed. And he's got machine guns. Wait until the army comes. I'm going to call they're coming soon." And he says, "No, I don't need any army. All by myself, I'm going to go in and save her." And he runs into the building. He kills the thousands of armed men. And then at the end, there's the big bad guy who's heavily armed and strong, but they have a fight, and at the very, very end, he kills the bad guy, he kisses the girl, and the army arrives, but he doesn't need them. He's a real man. All by himself, he solved his problems. He didn't ask for advice. He didn't get any help from anyone. And that's, part of the traditional male image. And that is translated into data from research, which shows that men don't ask for help. Or they wait until things are so desperate before they ask for help that it's much harder to get help. And so we need to find better ways of reaching men. And so there are some ways by publicity. So for example, the publicity for helplines, a lot of the traditional publicity has been feminine publicity. When things are going bad, you need to talk about it. Now, posters, for example, Samaritans in the UK, they show a guy with muscles and tattoos, and he's working on a car. He's got a wrench in his hand, and it says, "Sometimes you need the right tools when you need to fix something. Call the Samaritans." So there's a possibility of changing these societal attitudes. There's a program that we developed in Montreal for the police, and one of the things about police is that they carry with them a means for committing suicide. They have a gun. And when police officers die by suicide, they almost always shoot themselves with their service revolver. And we know that access to means is a risk factor. Police have protective factors because they're screened for mental health problems. If someone has a serious mental health problem, hopefully they won't become a police officer. And in Montreal area, we evaluated the published things, a program to prevent suicides among police officers. So the first thing we did was a publicity campaign. Every single officer received a half day of training, basically about where do you get help, and if someone a fellow police officer, has problems, it's not just his responsibility. It's your problem too, and you have to talk to him about it and get help. And the supervisors and union representatives, our police are members of a trade union, like in Canada usually. And also, they started a telephone helpline where police answered the phone for other police. And this is a training session in Montreal, all the different areas. You don't have to read all this, but the bottom line is that when you compared the years, 11, 12 years before and after the program, the suicide rate for police officers in Montreal went down 78.9%, whereas the other police officers in the province of Quebec who didn't have the program, there was a slight increase of 11%, which suggests that this can actually save lives, this sort of program. Okay, I mentioned this before. Getting people to seek and follow treatment is as important as determining how to help people. I think I already said enough about this, but it's important we learn more, not just what works, but how do we get people to use it. Internet is the new frontier of suicide prevention. There are articles every week. There's a dozen or 20 new research articles on internet and suicide. Some of it talk about the dangers of encouraging suicide. Some of it talk about the protective factors. But the bottom line is that right now, when you want to find a good restaurant, you go on the internet. When you want to find a way to kill yourself, you go on the internet. When you want to decide, should I kill myself or not, and you want some information to help, you go on the internet. And when you want help, you go on the internet. There's no control of what you're going to get. And the important thing is to, this is a whole other talk, but Google and Facebook, Siri on your iPhone are all doing things when people are searching for suicide information to try to put people in contact with help. And, we can talk about this later if we want. Most of the research we have is about why people kill themselves. So we know how to make someone suicidal. There's enough research about that. We know all the horrible things that can happen to a person that increase their risk. But there's very little research on the people who have the same horrible things happen, but they don't even think of suicide, or they don't go ahead. Or even if they're thinking about it, they change their minds, which are much greater in number than the people who actually die by suicide, but we don't study them. So we need to know more about protective factors. We already know a lot about risk factors. Coping skills. Zippy's Friends, international program, teaches young children here, 6, 7 years old in Lithuania, how to cope with everyday problems in schools. It was first tested in Lithuania. Now, 1.4 million children in over 30 countries are participating in Zippy's Friends. There's a new program for older children we developed. It's called Passport Skills for Life. Teaches how to cope. How do you learn how to cope with problems? You just follow the patterns of your parents or whatever. A lot of us have poorer coping skills than we should have, and you can teach coping, and there's research on this. Now, when you look at the research, something very strange comes out. Every published study, except one, and I'm the author of that one, found that lay people and volunteers are more effective at helping someone in a suicidal crisis than professionals. In fact, the more diplomas you have, the less effective you are. How do you explain this paradoxical finding? The explanation that's been given is that professionals diagnose and focus on problem, and they have a sort of rigid way of dealing with things, and they focus on the problem, whereas a lot of lay people will focus on the person and on building hope in even the most hopeless situations. For example, I'll give you a cultural example. In Rwanda, after the genocide in Rwanda, the Red Cross sent in psychologists. And the psychologists went to people who were feeling very, very down and depressed, and they brought them into a tent and they sat them down, they talked with them, and it was a total failure. After a certain length of time, no one would come. And and they tried to understand what's going on, because these were skilled professionals. And then they started asking people, well, what do you do when you're feeling down and depressed and horrible things have happened to you? And they said, well, the first thing you do is you need lots of sunlight. And so they took them out of the sunlight and brought them in these sort of dark, dingy tents. And then they said, you have to be supported by your family and friends. They took them away from the family and friends and brought them in with a single psychotherapist who was a stranger. And then they said, the most important thing is to talk about positive things. What did the psychologists say? What happened to you during the genocide? They talk about all the horrible things. So it was the opposite of culturally what was accepted in that situation. Now, what I'm going to share with you very, very briefly, it's another topic of a workshop for several hours, is partly based upon some experiences working in refugee camps in Africa. And basically in working with people, doing training with people who work with refugees. And I show you these pictures because these children, they're not happy. They're going through a very difficult situation. And whenever I did a workshop on suicide prevention, it might be a big group like this, and sometime during the first 3 minutes, I would start doing this workshop, and someone would always ask the exact same thing. And it would be something like, there's this man, and he said that he was going to kill himself. And he is from Somalia. Now he's in this refugee camp in Tanzania. And he witnessed his wife and children tortured to death before his eyes. He's all alone here. People are speaking another language. He used to have a business and a home and a family. Now he has nothing. He's been here for 10 years. He has no hope of going home. He says he wants to kill himself. If I was in that situation, I'd want to kill myself. How can I help him? How can I prevent suicide? And the answer to that is, that man's been living in that camp for 10 years. Something has been keeping him alive for those 10 years. He's not dead. There's something keeping him alive. Your goal is to identify what that is and to reinforce it. And so what are some of the techniques to do this? Some strategies. Simple things. You validate the person. You say things like, it took a lot of courage for you to talk to me about this. Be real. One of the strange research results we had on telephone helplines is that helpers who shared personal information were more effective than those who didn't. And therapists and others, you say, you never share personal information. You avoid it. Someone says, are you married? And you say, you're interested in my marital status. You don't answer those things. But people who actually shared information were more effective. And when we looked at what was going on, it wasn't that, someone said, I'm depressed, and the therapist said, the telephone helper said, you think you're depressed? Well, I had no, it was usually to share something to create a bond. So the person said, I had a really difficult divorce. And you say, I know how you feel. I had a horrible divorce too. Without going into the details, let me tell you about my divorce. No, not that. Okay. listen, give something back. Compliment people. We don't learn to compliment enough. And if you spend most of your time talking about the person's problems and difficulties, you're going to go nowhere. You have to spend almost all the time talking about the person's strengths and reasons for living, not the problems. So how do you do that? You have to assume the person has assets and strengths and is doing things to cope with the situation. If you ask, did you do anything to make yourself feel better this week? The answer is always no. But if you assume that the person has, and you say, what did you do this week that made you feel a little bit better? You try to get into those sorts of things. Change the perception. Tell me about a time, I know that you're going through a very difficult situation, you're feeling very bad. Tell me about a time this week when things were not so bad. Oh, they're always bad. Well, what about tell me about a time when they were a little less bad. And then, what were you doing? Well, I was making some tea and thinking about how it used to be. What type of tea do you make? Where were you sitting? And you try to get into those sorts of things. Physical needs, that's specific to refugee situations. When you're hungry, things seem a lot more desperate than when you're not hungry. And and it works. Building hope works. I'm going to tell you in 2 minutes about Quebec. Quebec had an increasing suicide rate. We had, for a while, the highest rate in Canada. It was going up every year up to 1999. And people had all sorts of interpretations of this. They said it's because in Quebec, which used to be mostly Catholic, and everyone used to go to church, and in 1970s, when the Independence Party came into power, everyone threw the church out of the hospitals and schools. People stopped going to church. It's a long cultural story to this. But people said, oh, the suicide rates are going up because people aren't going to church, or it's the economy, or it's this or that. But every year the rates went up, and they've been going down every year since 1999. Well, what happened then? There's ways of determining when things change. And the rates have been going down for all age groups, men and women, most dramatically in young people, 15 to 34 in men, and women 15 to 19. In fact, in the first 10 years since 1999, the youth suicide rate became half what it was before. And all regions except two very small regions, and almost all methods. And up until today, the rates are still going down every year, where for the 20 years before, they were going up every year. For example, this is the suicide rate for men aged 15 to 19. On average, every year the rate went up 2.8%, 1999. Since then, it went down almost 10% every year since. Well, what happened? 1998, Quebec had the government passed a suicide prevention strategy, which was really it sort of follows the World Health Organization guidelines of a range of different things, not just treating mental health problems and not just crisis services, but training and trying to change attitudes. And this probably is the best hypothesis because the economy wasn't doing great in '99. It wasn't a time when there were more jobs, there were less jobs, there was a bit of a crisis and so forth. So basically, I believe very strongly, and there are examples to prove it, that when you have a multi-determined problem, And suicide is not due to one thing. It's always a combination of risk factors and a lack of sufficient protective factors. You need to do lots of little things at the same time to have an impact on reducing suicide rates. Societal attitudes can change. People said, look, Quebecers they're just suicidal. It's part of the culture. I mean, they used to say that about smoking. When I started teaching, people would smoke in the classrooms. And there was nothing you could do about it. If you say no smoking, half the students would leave and come back during the class continually. Now, the idea of smoking in a classroom sounds ridiculous. Attitudes can change, and attitudes about suicide can change. The police program that I talked about is an example of how, in a very small, macho environment, police started asking for help more often and admitting they had problems and dealing with their problems and started helping each other. When things are bad, it's easy to find someone who's guilty. You should have seen the newspaper articles and television reports when rates were going up every year in Quebec. Everyone's saying, it's the baby boomers, that's a bad generation, or Quebec independence movement frustrations and making people frustrated. Everyone had a good explanation. But since the rates have been going down, we're not any more independent. The baby boomers are still there and they're killing themselves less frequently, and people are not going to church anymore. And so you have to watch those sort of generalizations. So my overall conclusion is that suicide can be prevented. And I think we'll stop now for some questions or comments.
You were mentioning about interesting correlation. As many psychiatrists are there, so perhaps in more well-to-do countries, so many more suicides per capita.
Yeah.
If it holds.
Yeah, it's not causal. I mean, it's, when you have a correlation, it could be due to anything else that's going on.
Correlation does not mean causal link.
Yeah.
But are there any also correlations? There's a lot of talk here, for example, that child psychiatry interventions can be helpful regarding coping mechanisms in later life. Is there any as well measurements or researches on how early childhood social or educational and psychiatric interventions?
Well, certainly, what happens early in life is a risk factor. There's a lot of research about negligence and abuse in early childhood as a risk factor for suicide, as it is a risk factor for many other things. But like all risk factors, whether or not that results in later on suicidal behavior will depend upon coping skills and help and social supports and a lot of other things. So it's always multi-determined, but certainly anything you can do, a part of a strategy would be to decrease early childhood trauma and negligence and abuse, but at the same time, building protective factors, because you're not going to be able to stop all abuse and all negligence and well, that and having help available and increasing coping skills, like being done in Lithuania with Zippy's friends, and maybe a new program soon, I hope. And so I think it's, there are a lot of different things that you can do, but it's very clear, that you're going to have a higher risk if you have an early trauma. There are people doing genetic research saying that there's some genetic vulnerability that needs, so it's an epigenetic research which needs to be catalyzed by having early trauma. This research has not, even though they keep coming up with something else that's correlated every year, it hasn't really come up with anything useful yet. But there are ethical issues involved, because if I do a genetic test on your child, and I say this child has a 10 times greater chance of suicide because of a genetic risk factor. It sounds, oh my goodness, my child's 10 times greater at risk. But suicide is very rare. So the risk goes from 0.01% to 0.1%. So 10 times greater, chances are very rare. But will I behave differently to that child knowing that? As a parent, will I make the risk greater by being overprotective or overly concerned that this is a psychiatric symptom every time he says, I'm not going to eat my peas? So there's issues, even if you can identify those genetic factors, how they could be responsibly used in some way. And even though it sounds very impressive, there's an association, big association, double the risk. Well, double a risk of 10 or in Lithuania, 30 per 100,000 is still 60 per 100,000. It's almost no risk. So we have to watch those issues, yeah. Yes.
First of all, thank you very much for the lecture. And I just have one quick question. I was very curious about that. The guy who was saved by a sea lion. So I just would like to read up about
his name is Kevin Hines, Hines, and his first name is Kevin, Kevin. And if you Google him, you'll find all the information you want on him.
I'm curious, what's your stand on assisted suicide? And is it acceptable and so when?
Okay, this is a long, it sounds like a simple question, but it's not. Okay, assisted suicide is one of two methods of what's called now often medical assistance in dying. There's euthanasia, which is when a medical doctor ends your life for compassionate reasons. And then there's assisted suicide, is when a medical doctor provides you with the means to kill yourself, but you yourself take that. So usually assisted suicide is when a doctor prescribes a lethal medication which you can get and then take to die. And that's why it's called suicide. Now, both practices are currently legal in Belgium, the Netherlands, and Luxembourg, and in Canada under certain situations, and in Colombia. Assisted suicide only is legal in Switzerland, and it's legal in some United States states. And the requirements except for Belgium and the Netherlands, is that you must be terminally ill, that your death must be foreseeable. And in Canada, which just legalized it a few years ago, you need to be terminally ill, basically, to have access. In Belgium and the Netherlands, you need not be terminally ill. In fact, you could be suffering from a psychiatric disorder and say that your suffering is too much, and you can request that your life be ended. Although in the Netherlands, they have the requirement that any available treatment you have to have tried first before having access, and half of the requests are denied because there's some treatment. That's another story. And so the issue is this different from other suicides? and assisted suicide? Is the motivation different? And is this, a different situation? The countries that have legalized this say that this is a different phenomenon. Those where someone is terminally ill, they say this is different from someone dying for whom death is not on the horizon. It's a question of changing the timing of death and the manner of death for someone who's going to die anyway in the near future. Others say that you have a right to make a personal decision about whether or not to live or die. Well, anyone can kill themselves. You just go and do it. My own position is that anyone who expresses the desire to die by suicide or by any other means, including assisted suicide, I will do everything possible to try to help them find ways of continuing living, because that's what I do. So if you're going to go ahead and kill yourself and you don't want anyone to try to help you find ways of profiting from life, even if you're terminally ill, don't talk to me, because I'm going to do my utmost to help you, because I believe that even in the most desperate situations, for example, someone who is terminally ill, people who get good palliative care, people who request euthanasia and assisted suicide rarely have physical suffering. It's mostly a psychological suffering. They don't want to die in what they think is an undignified manner, or they don't want to die alone, or they have fears that can be alleviated. So there's also this whole area of palliative care, to, how to help people and so forth. I do believe personally that, it's your decision. If I want to kill myself, I'll go kill myself. But that's very different from whether you're going to ask me if I'm going to help you do it. Am I going to give you the means to do it? Or I'm going to facilitate that, because my experience is that people in even the most desperate situations generally will, go on to live fruitful and fulfilling lives, even if they've only got another month or two left in their life, that this is possible. So that's what I do, but I also respect people's individual determination. But if you talk with me, you've made a decision that part of you that wants to live is affirming itself by deciding to talk with me, of all people, because you know what I do. I work in suicide prevention. So even if you say I'm going to kill myself, you tell me that. My interpretation of that is that part of you wants it out. You're looking for that emergency escape in the cartoon. And that's why you decided to tell me, of all people, about that, or a helpline, or a professional in mental health. And because in order to kill yourself, it's not like a light switch. You're going to kill yourself or you're not kill yourself. You can be just 51% convinced that it's the right thing to do and go ahead and kill yourself, even though 49% you're saying, well, maybe this isn't the right thing to do. And sometimes that balance can be changed very quickly by that bottle of vodka might make me feel, it's hopeless, and go ahead and do it. And when I'm sober, it's rough, but I'm going to go on for a little while, maybe tomorrow or maybe another time, but I'm okay. Or life events can, calling a helpline and talking to someone. It doesn't cure the person of their problems. When you call a telephone crisis line, you've spent your life developing your problems. They're not going to cure your problems in 50 minutes. But what they can do is help you tolerate a situation where it's gotten worse and you're really at risk of going ahead and injuring yourself. And they can get you to sort of get on a path to maybe getting things a little bit better. But that doesn't mean you're not suicidal. So that's how I view things. I sort of answered the question without answering the question, but I think that's the brief answer.
I wanted for you to specify a little bit more about the part of bringing hope. You said that helpers should focus more on the strength and the coping skills of the person at risk.
Yeah.
And I find it quite contrary to my experience. For example, in gatekeeper training, usually the main task in the training is actually of volunteers or gatekeepers is actually to help them to bear the painful part of the story of the person at risk, not to run away from it to the positive side. So I want to understand better where.
Yeah. Well. I think I think they're wrong. I think that gatekeeper training is useful because for me, what gatekeeper training does is it trains people to openly talk about suicide, and just talking about a problem helps. And just having someone listen to our problems is helpful, even if no matter what happens, and encouraging people to talk and ask questions about a problem. Referring to sources of help is useful too. So gatekeepers are trained to refer to sources of help. But if you really want to be helpful to someone, unless it is an easily solvable problem where you can encourage the person to, have some solutions, which is rarely the case, but sometimes. I firmly believe that you should not spend your time exploring the problem because the person's just going to dig himself into this dark, depressed hole. If I start talking about how much I love the woman who just left me and how distraught I am and how all my plans in life have ended and I don't know what to do I'm just digging myself into this dark hole. But if you try to get to know me and say, well, what interests you in life? What excites you? And besides this relationship, what do you do? I know it's been horrible. You say you couldn't survive the week because you don't have this relationship anymore. What were the times during the week when you weren't thinking about it, when things were a little better? I'm going to start becoming in contact with the fact that I am capable of doing things to make myself feel better. And it's not all dark. And that's what hope is about. And I believe that there's a distortion in our training in terms of suicide prevention. Now, if you're a therapist and you want to solve people's problems, maybe you want to get into all the details of the problems and go through all the solutions and get them on the track and get them solving their problems. But my interest is not in solving your long-term problems. I'll leave that to the psychotherapists in the room. My interest is in preventing suicide. And you prevent suicide by building hope, by having the person experience that they're a good person, that they're a capable person. When I say you're really, courageous to be able to talk openly about these things, that you feel, hey, this guy who's, he thinks I'm courageous. that makes me feel better. I'm not so bad. Or, you know, you say I've messed up. I really messed up here, and I point out all the ways that you really succeeded. You say, well, maybe I messed that up on that, but I'm capable of succeeding. And just the experience that things are not really all equally bad at every moment of life, but there are moments when things are better, that makes you think about those times and feel hope. This is so I think that there's helping people really involves focusing on the positive aspects of the person and their situations. And it's my experience that it works too. Try it. Try it and see how people react.
So far you've been talking about suicide prevention. My question is about more like mental well-being and about the relationship between mental well-being and decreasing suicide rates. Do decreasing suicide rates mean increased mental well-being in the general population?
That's a difficult one because it's very strange. We have different levels of tolerance and expectations. It's like the research on marriage. You know that satisfaction with marriage is not necessarily correlated with the longevity of the marriage. That some people have horrible relationships, no matter how you assess it, and they never divorce. They will stay together forever. And other people have relationships which seem, by whatever standards, to be pretty good, but it's not enough. And I think the issue with suicide is that we have such individual differences into what our expectations are of happiness, for example. Some people don't expect a lot of happiness, and a little is plenty, and they're not at suicide risk because they're unhappy. It's just, that's the way it is. And I'm thinking of my mother right now. And other people, they have very high expectations, and when they're frustrated. And so for me, the issue is again coping. How do you cope, and can you cope effectively when you have problems? Because suicide is a very desperate, irreversible way of coping with the situation. And if you have good coping skills, no matter what your level of tolerance is or what's going on, you're going to get through it. And everyone has different coping skills that are functioning. Some people will just invest in their work and they're fine. Others will turn to drugs and they might be fine too. I'm not going to, judge how people cope. Obviously, people who use social support, that's the number one most effective coping skills. People who, when they have a problem, they seek help and support for those problems, are much more likely to get through those problems without being suicidal. But we vary in our confidence in using social support, our practice and ability in it. And again, men and women traditionally, though hopefully this is changing, have different patterns and ways and abilities to seek support and help when they're going through problems. And, and that's a societal issue. It's not just an individual issue.
Thank you for your lecture. And you told that you travel in the world a lot and you see different cultural contexts. Maybe you could you comment what are the cultural or societal triggers there are individual triggers, precipitating events, but societal or cultural triggers that like switches on the increasing rates of suicide.
See, I don't think it's that clear. I don't think you can clearly say it's this, because, you know, when a journalist talks to you and they say, why are the suicide rates so high in Lithuania? What are you going to say?
It's complicated.
Yeah, it's complicated. They don't want to hear it's complicated. The journalist can't put, you know, a headline, it's complicated. They want to know, bullying in schools is causing suicides, or cyberbullying over the internet, or this, or the economy is making people kill themselves, or too many people are living outside the country, or whatever, whatever it is. They want like one or two simple headlines. But I don't think we can go, there. I think that what I've mentioned before about openness to help seeking and talking about problems with others is a very powerful factor. And part of this is societal, particularly in terms of traditional male and female roles within society. So I think that's part of it. There are many places in the world where suicide is much more of a taboo. So, for example, in Uganda, if someone dies by suicide, no one will marry any member of that family. If someone hangs themselves, they will dig a hole under where they're hanging, cut the rope, and throw some dirt over the body and ask the family to buy the little piece of land. If someone dies in a home, some villages, they will set the home on fire with the body in it and destroy the home. Others, they will cut a hole in the side wall and take the body out through the hole because they can't go out through the front door. At the funeral, they will beat the body in front of the relatives if the person has died by suicide, and they won't be buried in a church with a church burial. So there are places where there are horrendous taboos about suicide, which make it difficult to talk about suicide. And but these things are changing, and to some extent those same taboos exist in countries like Canada and Lithuania, where but these are changing. And they change as people who have attempted suicide come out publicly and say, I attempted suicide, or people who bereave say, my son died by suicide. And in some instances, for example, in the United States, there are examples of members of the legislature who came out and talked about their son or daughter's suicide, and in an open way, in order to get funding for suicide prevention. So I think that there's a possibility for those sorts of changes, because in order to prevent suicides, we have to be able to talk about it, to say, I've been thinking about suicide and I'm worried about it, or I'm afraid, I'm going to do something and get some help, and not be fearful that the person's going to be rejecting or saying you're crazy and so forth. So, I think those are the sort of societal issues, which not just suicide, but mental health problems in general. And I think we still have a long way to go in terms of that. I will end now. If anyone has anything else they want to talk to me about, I'll stick around. Come and see me.
Please